So I will move on to the last speaker before the break. So we will have Professor Jan GRERSTENMAIER. He's a fellow of the Faculty of Radiology at the Royal College of Surgeons of the Ireland. And he is also he's a Faculty of Radiology at the Royal College of Surgeons in Ireland, and a fellow of the Royal College of Radiologists and a fellow of the Royal Australia and New Zealand College of Radiologists.
Good afternoon. My name is Jan GRERSTENMAIER. I'm a radiologist at Alfred Health in Melbourne, Australia. My specialty is abdominal imaging, but I'm also a member of the emergency radiology team here at the Alfred. So over the next 20 minutes or so, I'd like to talk about what the future holds for emergency radiology. But before we start, I'd like to briefly remind ourselves from where we've come. Old casualty departments had little, if anything, to do with imaging. And even up to this day, some radiology departments are located separate from A&E departments or emergency departments. For example, the old Southern General Hospital in Glasgow was located near the main building, but A&E was constructed somewhere along the tree line, some 100 meters away, and patients had to be transported by van if they needed a CT scan. Skull X-ray formed an important part of head injury workup until the mid-1990s, something hard to imagine nowadays. Old CT scanners were so slow that they were unsuitable for the assessment of unstable patients, and therefore they were also called the donut of death. Nowadays, we've got fast CT scanners at hand, and radiology departments are being redesigned to fit in an emergency department setting. For example, here an example from the United States, you can see CT scanners and reading rooms centrally located within the ED with direct access from resuscitation and treatment areas to the CT scanner room. It is now known for a number of years that whole body CT in severely injured patients in shock increase survival, and that is due to the improved imaging technology with fast CT scanners available across the board. Emergency radiology is a subspecialty that is unique because of the highly time-sensitive nature of the work. There must be 24/7 service provision, and it is a generalist specialty with all body parts and imaging modalities concerned. Establishment of emergency radiology is shown by the emergence of many societies and interest groups across the world. And with that comes the benefits of postgraduate training, continued professional development, and scientific meetings and journals. Although the clinic subject matter spans most other subspecialties, emergency radiology has its own requirements and obligations, and it is now felt that every practice should have at least one member whose responsibility is to manage this really important segment of a holistic radiology service. As an example, at Alfred Health, we've got a large ED and therefore a large emergency radiology department that consists of several scanners and a reporting room centrally located within the emergency department, literally around the corner from the trauma bay, and staffed 24/7 with at least one registrar who is directly contactable by ED or the trauma unit. We participate in the daily trauma handover meeting and weekly trauma audit. And we have one head of the emergency and trauma radiology group who act as a liaison as well with emergency and trauma radiology, but there are other radiologists part of the team. As with any subspecialty, we have close relationships with our referrers, and we know them quite well, which is very helpful for the day-to-day work. Some possible future developments that we look at are the extension of radiologist hours and the establishment of our own postgraduate trauma fellowship, emergency radiology and trauma fellowship. Some of the challenges that emergency radiology face are the changing demographics and an ever-increasing workload. The world population is changing, and although increasing in overall size, there's also a shift in the patients' ages. The demographic reversal, which is taking place in China around this time, where the proportion of over 60-year-olds is higher now than the proportion of under 14-year-olds. And with that comes its own set of clinical and imaging requirements because of different conditions across different age groups. Looking at figures from Taiwan, you can see annual ED visits and hospital admissions have remained steady over a 5-year period. However, the utilization of CT has increased by about 80%, which is huge, whereas the CT utilization with subsequent admission has only decreased by around 11%. In Iceland, the volume-adjusted imaging utilization by modality has markedly increased for CT, threefold approximately, with only a modest rise in ultrasound and MR. The volume-adjusted CT imaging utilization by patient age group show that the over 60 age group has had the highest increase of CT use. And the demand for after-hours imaging was mostly proportional to this overall trend. Now, if you think that is unique to Iceland, have a look at the data from the United States, where there is a similarly steep curve in terms of number of examinations per 1,000 population, CT as well as MRI. And you will also note that all examinations are reported by radiologists, with only radiographic imaging reported by some physicians and physician attendants. Just like emergency medicine, emergency radiology is not a 9-to-5 business. And although there are troughs and peaks throughout the daytime, there's really a 24/7 demand for imaging. And that is one of the necessities where emergency radiology need to respond to the requirement for a 24/7 service. In addition, the changing demographics and ever-increasing workloads are items that we need to respond to. So in essence, we're a workforce in crisis. There are staffing issues, not only concerning radiologists, but also radiographers, nurses, clericals, orderlies, cleaners, and anyone else that is required to run a CT scanner. And with that comes a cost explosion. If the demand is not met, then there may be delays in reporting and therefore diagnosis, affecting patient flow. Now, what are possible solutions for radiologist shortage and workload specifically? The use of clinical decision support tools is increasingly advocated, but also artificial intelligence is playing an increasingly important role, and teleradiology is a huge area that is continuing to grow or expected to continue to grow over the next years. Everyone knows the Ottawa rules for the knee and for the ankle, and this is one of the older clinical decision support tools that is successfully implemented and used in many departments. However, there are others, such as the American College of Radiology appropriateness criteria. And if you're not familiar with those, I would encourage you to look them up. They are available online and free. And you can type in clinical scenarios or specific conditions and get advice on the most appropriate type of imaging. For example, I've typed in acute pancreatitis, typical presentation. The question is, should the patient have a CT? Well, that depends on the clinical context, but not necessarily. And if so, it should be a contrast-enhanced CT. There is no role for an unenhanced CT in acute pancreatitis in this context. However, an ultrasound abdomen is appropriate in most cases. Now, Going back to the future, artificial intelligence is a very topical item that is debated and contemplated across departments. And it really comes down to reporting. Reporting consists of the detection of an abnormality, the interpretation and characterization of the abnormality, the integration into a clinical context, and the monitoring of the abnormality. So AI, artificial intelligence, AI has been implemented in oncology for some time. We detect lung cancers or lung nodules, breast cancers, and the AI aids in the characterization, for example, by aiding surgical planning. It is also used in monitoring over time of for example, of a lung lesion, how it changes in terms of size and overall appearance. However, in emergency radiology, AI is at present only a support tool, and it aids in the detection of an abnormality. It aids in workflow triage. It alerts us in a timely manner if there are critical conditions such as a brain hemorrhage, and therefore helps us in prioritizing certain examinations. For example, if there are 10 CT brains to be reported and an AI tool identifies a brain hemorrhage on CT brain number 8, that particular CT brain will be placed at the top of the queue for immediate reporting, and therefore improving and facilitating that particular patient's care, whereas the remaining 9 CT brains can safely wait. If you look at the process between requesting a examination and issuing a report, there are several steps involved, from ordering to protocoling, scheduling the scan, moving the patient to the scanner, acquisition of images, moving the patient out of the scanner, processing images, moving the images to PACS, reading out the images and issuing a report and communicating that by either a written report or telephoning the results through in case of urgent or critical findings. And at each of these steps, artificial intelligence can be used to support the processes. For example, during the protocoling stage, AI can aid in choosing an appropriate imaging protocol, taking out several minutes of a radiologist's time in practice. It can also be used for optimizing image acquisition and post-processing image quality improvement, and of course as a clinical decision support, and last but not least by image abnormality detection. So you can see AI can be used in a broad range of processes within an emergency radiology department, but it is still in an era of research and it's only starting to translate into clinical practice. And we unfortunately haven't clinically validated many processes, and they are not really being made available for wider users yet. And some of the roadblocks that there are a significant amount of technical efforts and financial commitments that are required. And obviously there are medical ethics considerations and certain levels of transparency. So a lot of work to be done in this area. Teleradiology is a growing field with many advantages, such as having a major impact on decreasing the report turnaround time, and also an overall improvement of the service levels within an emergency department setting. Because of its nature, there's been a strong peer review and quality assurance process required. And because teleradiology plays an important part in emergency imaging in particular, it has generated a group of generalist radiologists who have specialized in emergency imaging and therefore become very good at acute care imaging interpretation. And it is shown that the report quality as a result is enhanced. What I find most striking is the night-day model that teleradiology offers, namely that the radiologist sits in a different time zone at the other end of the world, and therefore during her or his daytime is much more productive and alert, and potentially leads to healthcare cost savings. The communication level between clinicians and radiologists remain high, despite a communication only occurring over the telephone. But there hasn't been shown to be much difference between on-site radiology. On the contrary, there are some negatives about teleradiology, namely the subject to certain regulations that are jurisdiction specific, and the nature of the business. Teleradiologist providers, by and large, are for-profit organization, and with that comes a risk of corporatization and predatory practices. Here's an example of a teleradiology company, Everlight Radiology, that just illustrates the flow from the patient attending a hospital and requiring a scan, which is being requested by the emergency physician. The scan is being acquired on site, and the imaging data is being transmitted to the company that then distributes it to one of their radiologists who could be physically located anywhere. They look at the imaging, issue a report, which then gets transmitted to the referring institution. And the turnaround times that can be achieved range typically between 30 minutes for super urgent exams, such as a perfusion CT brain in suspected stroke, or a 2-hour turnaround time in a less emergent clinical setting. There are some imaging technologies that have been used routinely for a number of years now, but that are only now being brought into emergency radiology. As an example, CT coronary angiography in the ED setting has been shown to be of benefit in patients presenting with chest pain and a low to intermediate risk of acute coronary syndrome, because it allows safe and expedited discharge and therefore prevents unnecessary admission and prolonged length of stay. To finish up, some of the new techniques are being developed. For example, as a result of the COVID-19 pandemic, this technology was developed at Alfred Health, where X-rays are being taken through a glass, therefore minimizing the exposure of radiography staff to potentially infected or confirmed patients. It looks simple, but it involves a huge amount of work in terms of radiation protection and maintaining image quality if you send X-rays through a glass door and through the patient onto the X-ray detector. But this has been shown a very successful intervention and has been implemented successfully in our department and in fact in departments across the world. And it was published in 2020, which is a year that we don't really want to go back to. And with that, I'd like to conclude and would like to thank you for your attention.
Hello, thank you very much, Professor Yan. I will have a few questions to ask you. If you don't mind, please. So I'm very interested in the specialized emergency radiology service in your hospital. So,
Yes.
do you think it is only possible in the Alfred, where it is the major trauma referral center in the whole Victoria, or do you see it developing in like in Hong Kong, where there are multiple small trauma centers in a big urban area?
I think it's possible in a variety of settings. Some of the requirements are obviously the staffing levels and also the radiologist's interest in the subject. So emergency radiology can be quite an attractive subspecialty. So if you have a group of radiologists who have an interest and show some dedication to the subject, and if there is enough staffing in the radiology department to allocate or assign a number of radiologists specifically to emergency medicine, I think then it is possible, even if it is not a major trauma center as such. But I'm not too familiar with the Hong Kong hospital environment, but my understanding is that many hospitals are acute hospitals, so they provide acute services. Yeah, so that's my take on things.
Okay. And do you actually see the other way around where an emergency physician receiving extra training in radiology taking up that same role?
I think emergency physicians, like many other clinicians, should and can and are able to read certain imaging studies to an extent. Like a surgeon can read a CT abdomen, and I expect an emergency physician to read a CT brain. But many of the emergency radiology studies that are done nowadays, they are highly specialized and they require many years of training and ongoing high volume practice. Like, for example, a CT perfusion brain is a very complex study, and if I wouldn't expect an emergency medicine simply to have the time to dedicate sticking to a level where they read a high volume and they are competent and able to interpret those studies. So to an extent, yes, but a lot of imaging gets more and more complex.
Okay. So thank you very much. So there is no more questions. So that conclude the section before the break.
Okay.
Thank you.
Thank you very much.